Is everyone hearing me properly?
Yes, sir.
Okay, just confirm that you are seeing the slides also.
Yes, sir.
Okay, then shall we start?
Okay, sir.
Okay. Yesterday we had talked about the normal hemostasis. How does the primary hemostasis occurs primarily? Okay. Yesterday we had talked till the formation of the primary hemostatic plug, and then briefly about the secondary hemostatic plug and what are the mechanisms that and what are the mechanisms in primary hemostasis, and what are the factors that play a role in the hemostasis. Okay, and we had told that endothelium, platelets, and platelet endothelial cell interaction and clotting cascade are the factors which play a great role in hemostasis. And then we talked about endothelium. Okay, so in endothelium, briefly I would like to revise that in heparin-like molecule, there will be heparin-like molecules which will inactivate the thrombin along with the factors 9A and 10A. Okay, so it will inhibit the thrombosis along with tissue factor pathway inhibitor, which inactivates the factor, inactivates the tissue factor and factor 7A activated complex. And there will be thrombomodulin, which will inactivate the factor 5A and 8A in presence of factor C and protein C and protein S. Okay. Today we'll start with platelets. So platelet is also very important. Yesterday we had talked. Let me take you back to one figure here. This is a very important figure which talks about the role of platelets in primary and secondary hemostasis. Okay. Yesterday also I had emphasized a lot on this particular thing. And the endothelium, the platelets, and the interaction between the platelet and the endothelium. Whenever there is a breach in the endothelium, that is due to either trauma, okay, or even in some inflammatory conditions, and like sepsis, there will be endothelial activation. Okay, and you can see here that after the trauma, there will be exposure of the subendothelial collagen, where there will be von Willebrand factor. They will be residing in the subendothelial area. So they will be exposed, and these platelets will come and bind with the help of GP1B receptors. And they will have group glycoprotein 2B, 3A receptors also in the platelets, and they will come and aggregate after the adhesion of the platelet. After the adhesion of the platelet to the von Willebrand factor, then more platelets will come and adhere. That is known as aggregation. This is adhesion. Now this is aggregation. Okay, and this adhesion is due to the GP1B and the von Willebrand factor, and this aggregation is due to the GP2B3A receptor. So whenever there is a deficiency in the von Willebrand factor, then it might also cause bleeding. So this is known as von Willebrand disease. Whenever there is a deficiency of GP1B, it is known as Bernard-Sollier syndrome. And whenever there is deficiency or abnormality of the GP2B3 receptor, then it is known as Glanzmann thrombasthenia. Okay, Bernard-Sollier syndrome, Glanzmann thrombasthenia, and von Willebrand factor. This you have to know. So these primarily come in primary hemostasis. So these platelets, they are disc-shaped anucleate cell fragments from the megakaryocytes in the bone marrow. They helps in forming of the hemostatic plug and seals the vascular defect which has been caused by the injury. And there are several glycoprotein receptors like GP1B, GP2B3A, which we have already talked about. This helps in adhesion to the bone Wilbrand factor. It helps in aggregation. Okay. And there will be granules in the platelets, either alpha granules or delta granules. And after platelet injury, after vascular injury, there will be platelet adhesion. This already you know. These are the things what happens to the platelets. Okay, first of all, there will be platelet adhesion. Then there will be release reaction. These release reactions will lead to release of the calcium, ADP, and negatively charged phospholipid on the surface. This calcium, ADP, this ADP is also required for aggregation of the more platelets in that area of the injury. And there is expression of the negatively charged phospholipid on the surface. Now, this is for the initiation of the secondary hemostasis. So, for the initiation of the coagulation cascade or for the propagation of the initiation coagulation cascade, negatively charged phospholipid is essential. So this is also provided by the platelet, and there will be platelet aggregation. Platelet aggregation will be due to GP2B3A. ADP and thromboxane A2 also amplifies the platelet aggregation. So there will be formation of the primary hemostatic plug, and due to this release reaction, there is calcium release, ADP release, and negatively charged phospholipid on the surface. So it will lead to the formation of secondary hemostatic plug with fibrin crosslinks. Now let's come to the secondary hemostasis, which is due to the coagulation cascade. Now we have finished the primary hemostasis. Now let's go to the coagulation cascade. So it is a series of amplifying enzymatic reactions that lead to the deposition of an insoluble fibrin clot. This, since yesterday, we have been talking many times. So in this coagulation cascade, this is a series of enzymatic reactions where the inactive proenzymes are converted into activated enzymes, and ultimately there will be the soluble fibrinogen will be turned into insoluble fibrin, and they will be cross-linked to the primary platelet plug and make it stable. Okay, like for example, a proenzyme, which is the inactivated factor. For example, let's say factor 7, which is the most important factor in the extrinsic pathway of the coagulation. Okay, in presence of a cofactor, calcium and phospholipid, for example, okay, it will be changed into activated factor. Now we can see here, this is the coagulation cascade where we have intrinsic pathway, extrinsic pathway, and both will culminate into a common pathway. This is the common pathway. Ultimately, in between there is factor 10. Okay, there is factor 10. Both will both intrinsic pathway and extrinsic pathway, they will both come and converge into a common pathway. So here you can see extrinsic pathway, whenever there is an injury, there will be exposure of the tissue factor, which is also known as thromboplastin. Okay, due to this cofactor, now the factor 7 will be changed into factor 7 activated. So you can see here, this factor 7 is a proenzyme. Now with presence of a cofactor, here it is a thromboplastin or tissue factor. Now it is changed into factor 7 activated. Okay, and now it will directly activate the factor 10 in presence of calcium and phospholipid surface. So this is the phospholipid surface, which is given by the platelets. Okay, now this is turning into a activated factor. Then again, in the presence of calcium and phospholipid surface, now it is changing the prothrombin into the thrombin. This is the common pathway. Okay, and this thrombin is activating two things here at last. One is fibrinogen to fibrin. Fibrinogen to fibrin. Fibrinogen is soluble, whereas fibrin is insoluble, which will cross-link the primary hemostatic plug. And next is factor 13. It will change the factor 13 to the factor 13 activated, which will cross-link the fibrin. Okay, so only presence of fibrin is also not adequate. There should be a factor 13 also, which helps in cross-linking of this activated fibrin. Okay, so this is about the extrinsic pathway and the common pathway. Now the intrinsic pathway, it starts with a Heisman factor known as factor 12. Okay, so in presence of high molecular weight kininogen collagen, okay, then there will be change of factor 12 to factor 12 activated, and in the same reaction, pre-kallikrein will be changed to kallikrein. Okay, and then these all factors you can see will ultimately, there will be a sequential reaction from here to here, intrinsic pathway to the common pathway, extrinsic pathway to the common pathway. Here you can see factor 12, factor 9, factor 11, okay, factor 8, factor 5, factor 2. Okay, so there is a sequential events ultimately leading to formation of a fibrin, and in many of the reaction, calcium and phospholipid surface is required. So there are almost 13 factors. Okay, these are the names. Factor number one is fibrinogen, 2 is prothrombin, 3 is tissue factor or tissue thromboplastin. So this is a factor 3. This fibrinogen is factor 1, prothrombin is factor 2. Okay, so similarly there are names of all the factors. The clotting factors are synthesized by the liver, and 4 clotting factors, especially I'll be back in just a minute. Okay, let's resume. Any problem till this one? Anyone? Any problem till this one? If you have any problem, then let me know. I'll be happy to clarify. So you have to know that vitamin K dependence coagulation factors are also there, which are 2, 7, 9, and 10. This is very, very important, and you should know. So the clotting factors are synthesized in by the liver. These clotting factors are also protein. Okay, so these proteins are being synthesized in the liver, and there are vitamin K dependent clotting factors, which are 2, 7, 9, and 10. The intrinsic pathway starts with a contact between the negatively charged surface, collagen, and the factor 12, whereas extrinsic pathway starts after the exposure of the tissue factor or the thromboplastin to the factor 7. This we have already talked. This is very, very important. You should know how the sequential event is going, and they are converging into the common pathway. So here you see this is the extrinsic pathway, and here in extrinsic pathway just two things are there. One is factor 7 and tissue factor or thromboplastin. Whereas here there are many factors, starting from the factor 12, and ultimately factor 8 and factor 8 and factor 9 activated. Okay, and which are combinedly activating the factor 10 in the common pathway. So if any of the factor, there are many factors, if any of the factor along with the phospholipid surface, calcium, okay, thrombin, if this is because thrombin, apart from formation here, the thrombin is also a cofactor in many of the reactions. So there might be absence or problem with any of the factors. So this will also lead to ultimately blockage of the formation of the fibrin and leading to a bleeding disorder. So we also have to know the role of thrombin in hemostasis and cellular activation. This thrombin, I have already shown you, it catalyzes the step in the coagulation cascade, okay, and it induces platelet aggregation and thromboxane A2 production. This thromboxane A2 also indirectly helps in platelet aggregation. It activates the endothelial cells to express the adhesion molecules and variety of fibrinolytic, vasoactive, and cytokine mediators. Okay, like fibrinolytic is tissue plasminogen activator. Vasoactive means nitric oxide and prostacyclin, and cytokine mediators like platelet-derived growth factors, and they also directly activate leukocytes. So these are all the features of thrombin, how it helps in hemostasis and the cellular activation. Here you can see it is helping formation of the thromboxane A2 and platelet aggregation, okay, and helping in nitric oxide, prostacyclin, and tissue plasminogen activator formation, okay, and it directly inactivates the leukocytes like neutrophils, monocytes, lymphocytes, okay, and it expresses PDGF, platelet-derived growth factors. Now, fibrinolysis. Yesterday also briefly we had talked about fibrinolysis. So the fibrinolysis, why fibrinolysis is essential? Because to limit the process of formation of a thrombus, or not actually a thrombus but a clot, okay, in the only the area of need. This is achieved mostly through the activity of the plasmin, okay, which is made from plasminogen, which breaks down the fibrin and interferes with the polymerization. The fibrin degradation products, they are also the weak anticoagulants. After breakdown of the fibrin, there will be production of the fibrin degradation products. Now, they are also the weak anticoagulants. And it prevents excess plasmin from lysing thrombi, and the free plasmin is rapidly inactivated by the alpha-2 plasmin inhibitor. Okay, here it is showing in the picture. Here you can see there is presence of a clot. Okay, so This is the area where there is endothelial injury. So apart from this area, if there is presence of the fibrin clot, okay, there should be plasmin, okay, plasminogen, which breaks down the fibrin and interferes with the polymerization. Here you can see there is breakdown of the fibrin strands by the plasmin. So ultimately, we know that there should be a very close balance between a procoagulant state and a anticoagulant state. Okay, there should be a very close balance between a procoagulant and a anticoagulant state. So whenever there is a need of anticoagulation, okay, then there should be anticoagulation, and whenever there is a trauma leading to a coagulation, then this will shift towards the procoagulant state, and there will be formation of a hemostatic plug, initially primary, then secondary. And we have talked about these many things, which is about the normal hemostasis, and you should know all these things. This is for this part. Okay, this we were supposed to finish yesterday. Now we'll start today's topic. So any problem with normal hemostasis? Anyone? I'll give 2 minutes. If any problem, we'll go very slowly. If any problem you have not understood anything, then we can revise it time and again. Yes or no? If you don't have problem, please let me know that you don't have a problem.
No problem, sir. Let's move forward.
Okay, then let's move forward. Now we are talking about the laboratory evaluation of bleeding disorders. We are today talking about the screening tests, not about the specific tests. Okay. So whenever there is a bleeding disorder in any patient, then whenever there is a bleeding disorder in any patient, then we have to do initially the screening test. Okay, we have to do the screening test. Now you have to keep in mind the normal hemostasis. When we do the screening test, we will check the normal hemostasis. Where is the problem? Either in the primary hemostasis or the secondary hemostasis. And in primary hemostasis also, what is the problem with? Okay, but more specifically, we'll do that in the specific tests. But now let's talk about the screening tests. So screening test for the bleeding disorders, we do the test for the primary hemostasis and test for the secondary hemostasis. In test for the primary hemostasis, we do the bleeding time, platelet count, and for the quantification of the platelets, and blood smear for the quantitative and morphological abnormalities of the platelets, and detection of the underlying hematological disorder, which is leading to the thrombocytopenia. Okay. So bleeding time. Just a second. Okay, the bleeding time. This is the in vivo measure of primary hemostasis, which looks after the vascular and the platelet components. Okay, means in the vascular component we are looking mainly the von Willebrand factor, and the platelet components. Either platelets are there or not adequate to come and adhere and aggregate wherever there is a trauma to the vessel. Okay, and assist the formation of the primary hemostatic plug following a skin puncture or the incision, and is dependent on the adequate functioning and number of the platelets along with the von Willebrand factor. Now you just try to recap the normal hemostasis. In the normal hemostasis, in the primary hemostasis, initially whenever there is exposure of the von Willebrand factor, platelet has to come there, and there should be normal von Willebrand factor, then the platelet has to come, okay, and adhere there with GP1B receptor, and then they should come and aggregate. So this bleeding time will look these things. Methods for BT. Now, the time required for bleeding to cease following a skin puncture or incision is measured, and the stoppage of bleeding indicates the formation of a primary hemostatic plug, and it is done by finger prick method, Duke's method, IV's method, or template method. Okay, this Duke's method, it is not recommended, but still some institutes are doing it now also. In Duke's method, we measure the BT following the earlobe puncture. It can cause a large local hematoma in the ear, so this is not recommended. Whereas IV's method is a recommended method where 2 to 3 standard punctures are made on the volar surface of the forearm with a lancet. Lancet is a instrument, here you can see, which punctures the skin. This is a lancet. It will be sterile. Okay, we just break this, take it out, and there will be a sharp needle which will make punctures. 2 to 3 punctures will make in the forearm. And there should be a pressure of 40 millimeter of mercury, and it should be constant. So for that we use a sphygmomanometer, which is used for blood pressure measurement. So we keep it in 40 millimeter of mercury, 40 mmHg. Okay, and then after keeping it in constant pressure of 40 millimeter of mercury, then we make 2 to 3 incisions or pricks with the help of the lancet, and stopwatch is started as soon as the puncture is made, and the blood which is oozing out is blotted at the regular interval. And the time taken for each puncture wound to stop bleeding is noted, and average time is the bleeding time. So we already know this. The template method, it is similar to IV's method, but nothing is different. But the only difference is that it uses a special surgical blade which makes a larger cut, almost half to 1 centimeter. Okay, 6 to 9 mm long and 1 mm deep. And you need not fear because the 1 to 2 mm depth of the cut is not that deep.
Sir, you got muted.
How did I get muted? So the normal range for the bleeding time is 3 to 5 minutes in Duke's method and 3 to 8 minutes in the IV's method. Is that okay? Now, what are the causes of the prolongation of this bleeding time? Obviously, this bleeding time is related to the number and function of the platelets. So whenever there is thrombocytopenia means decrease in platelet count. The normal range of the platelet in human body is 1.5 lakhs to 4 lakhs per cubic millimeter. So if it is less than 1.5 lakhs, there is thrombocytopenia. Whenever there is thrombocytopenia, it will lead to increase in bleeding time. Or disorders of the platelets can be there, like Glanzmann's thrombasthenia, Bernard-Soulier syndrome, or uremia, myeloproliferative neoplasms, leukemias, myelodysplastic syndrome, disseminated intravascular coagulation, and aspirin. The patient which is also taking aspirin, okay, will have disorder of the platelet function leading to the prolongation of the bleeding time. So the patients which have a tendency to have a formation of a thrombosis, okay, will be given aspirin. And inherited disorders like von Willebrand disease or afibrinogenemia and other vascular disorders also will lead to prolongation of the bleeding time. You have to know thrombocytopenia. One is number of the platelets, and next is disorders of the platelet function, and then inherited disorders like von Willebrand disease, afibrinogenemia, other vascular disorders. Okay, so first and foremost, we go with the platelet count to access the number of the platelets using either an automated hematology cell analyzer in larger centers, whereas we can manually see under a microscope using a Newberg chamber. So what is a Newberg chamber? How the counts are done in the Newberg chamber, that you will know after coming to the college and while we do the practicals. So the normal range of the platelets is, we have already talked, 1.5 to 4 lakhs per millimeter cube, and thrombocytopenia is below 1.5 lakhs. The common causes of thrombocytopenia: hematological malignancies can be there, DIC, disseminated intravascular coagulation, which we will talk later in the later part of the bleeding disorder, and ITP also, idiopathic thrombocytic purpura also we will be talking in the, these two we will be covering in the later part of the bleeding disorders. And apart from those, connective tissue diseases, megaloblastic anemia and aplastic anemia will lead to thrombocytopenia. So here are a list of thrombocytopenia clinical diseases which will lead to thrombocytopenia. Okay, but if you know these things, Okay. For the prolongation of the bleeding time, these things, and for the thrombocytopenia, these things, then it will be okay. And if you want to know more, you have to go through this. Although this is not related to the bleeding disorder, okay, thrombocytosis means increase in number of the platelet can occur in inflammation following hemorrhage and myeloproliferative disorders like CML, chronic myeloproliferative neoplasm in CML. Okay. And we can do platelet function test. One is the number of the platelet. The second is the function of the platelet. So whether the platelets are aggregating or not after adding some substance like ADP or collagen. So if there is inadequate platelet function, they won't adhere. There won't be aggregation. Otherwise, we can do PFA 100, which is an automatic functional analyzer for the platelets. Now we come for the screening test for secondary hemostasis. In the primary hemostasis, we looked for the platelet count, 1, and bleeding time. Okay, bleeding time and platelet count, and other is platelet function. So these three things we looked in the screening test for the primary hemostasis. And whenever there is either a decrease in number of the platelet or function of the platelet is deranged, or there is any problem with the vessels, okay, or there is von Willebrand factor deficiency or deficiency of any other things like GP1B or GP2B3A, then there will be increase in the bleeding time. Any problem till this? Any problem, class? Shall we move forward?
Yes, sir.
Okay. I hope you are
Yes,
understanding.
sir.
I hope you are understanding, everyone.
Yes, sir.
Okay, because this is very, very important, and this is a very basic thing. So now we do a screening test for secondary hemostasis. After a patient comes with a bleeding disorder, now you have to know initially whether it is a defect of the primary hemostasis or the secondary hemostasis. Okay. In secondary hemostasis, you screening test, you look for the clotting time, the prothrombin time, and the activated partial thromboplastin time. Okay, also known as APTT, and for prothrombin time PT, clotting time CT. So the clotting time, it is not that very good investigation, but still we are doing. This is a screening test for coagulation disorder. This is a crude test and is affected by a number of variables. That's why this is not a very good test. And this is usually prolonged when there is a severe deficiency of the coagulation factors in intrinsic or the common pathways. Okay, either in the intrinsic or the common pathways. And it might be normal if there is only mild to moderate deficiency of the clotting factors. But now it has been replaced by APTT, because APTT also looks after the intrinsic and the common pathway, whereas PT looks after the prothrombin time, looks after the extrinsic pathway. Okay. Methods for clotting time, we do a capillary tube method and Lee and White method, which I think you will be doing in the physiology part, but still we'll be going through it briefly, we'll fill in the capillary tube method. We'll fill 2 capillary tubes with free flowing blood from the puncture like this. Okay, there is a we have made a finger prick. Okay, and there is a blood. So we take a capillary tube and be sure to ensure that ensure yourself and you are safe with a globe. Okay, and with this free flowing blood from the puncture of the fingertip, you fill 2 capillary tubes and you wait for 2 minutes and start breaking the capillary tube at 1 centimeter distance to see whether there is formation of a thin fibrin strand or not, and calculate the average time of that formation of the fibrin strand and express it in seconds or minutes. Okay, like here, if you break, if there is presence of a fibrin thread, then that is the clotting time, the initial state when you find the formation of the thread, that is the clotting time. But that is not used nowadays generally. This is a very crude test, and there are many variables which affect the clotting time, so we do not use it. Now the Lee and White method, this is although not used very widely because this has been replaced by the APTT. Okay, however, for this we draw 3 ml of blood in the syringe and transfer 1 ml of blood into each 3 glass tube, which are kept at 37 degrees centigrade in water bath. And after 3 minutes, we tilt the tubes one by one every 30 seconds. And the clotting time is the time taken when the tubes can be tilted without spilling of their contents. Like this, we in the 3 different tubes, we keep 1 ml of the blood in each test tube, and we keep those test tubes in water bath at 37 degree centigrade, because the body temperature is 37 degrees centigrade. Okay, so we tilt the test tube every 30 second after 30 minutes. Okay, and we see if there is formation of the clot or not. So the time at which there is formation of the clot and there is no spilling of the contents, that is the clotting time. Okay, the normal clotting time is, if capillary tube method is used, then 1 to 5 minutes normally, and Lee and White method 5 to 10 minutes normally. Okay, now the prothrombin time. The prothrombin time, it measures the extrinsic and the common pathway. Extrinsic means where the factor 7 was there, the tissue factor and the factor 7. Okay, here in prothrombin time we add tissue thromboplastin and calcium, which are added to the platelet pore plasma. Why platelet pore plasma? Because platelet is a very important factor for the primary hemostasis. So there can be a false positive result due to the presence of this platelet. There can be presence of the primary hemostasis aggregation. So we can think that that is the presence of the clot. So for that we make a platelet pore plasma, and in that plasma we are adding tissue thromboplastin and calcium, and the clotting time of the mixture is noted. The normal prothrombin time is 11 to 16 seconds, and just try to see this again. See this. This is the extrinsic pathway, and this is the common pathway. So PT looks after the extrinsic pathway, and the common pathway both. So it looks after factor 7, tissue factor, factor 10, factor 5, prothrombin, fibrinogen, and factor 13. Okay. So whenever there is a prolonged PT, it should either be due to deficiency of factor 7 or tissue factor, or one of these factors in the common pathway. So inherited deficiency of a coagulation factor in the extrinsic or the common pathway, like factor 7, 8, 5, 2, or 1, and vitamin K deficiency, because the vitamin K dependent factors are 2, 7, 9, 10. Okay, 2, 7, 9, 10. But only these three factors come under the either extrinsic or common pathway, and 9 is towards the intrinsic pathway. See here, 9 is towards the intrinsic pathway. So if there is vitamin K deficiency, then also the factors 2, 7, 9, and 10 will be decreased, and that will lead to increase in the PT. And if the patient is on anticoagulation therapy like aspirin, it interferes with the carboxylation of the vitamin K dependent factors, ultimately leading to the increase in PT. And in disseminated intravascular coagulation also, there will be consumption of the coagulation factors, okay, leading to increase in the PT or prolonged PT. So whenever there is increased PT, that is either due to the abnormality or deficiency in extrinsic factors of the extrinsic pathway or the common pathway. But whenever there is a problem with the APTT, then there is a problem with the intrinsic pathway or the common pathway. So let's go to the APTT, activated partial thromboplastin time. It assesses the intrinsic and the common clotting pathways. So for this, we see the clotting of the plasma after addition of the kaolin, cephalin, and calcium. So this kaolin, it activates the contact dependent factor, which is factor 12, and cephalin, it is a substitute for platelet phospholipid. Like I had told you that platelet phospholipids are required. Okay, negatively charged phospholipid surface is required for the coagulation cascade to go on. So that is given by the cephalin, and calcium is also needed for the coagulation cascade. So whatever is needed we give, and we see for the clotting, and whenever the clotting starts, that is the activated partial thromboplastin time. So the normal range is 30 to 40 seconds, which is slightly larger, more than that of the PT. PT was 11 to 16 seconds, whereas APTT is 30 to 40 seconds. Now, prolonged APTT can be because of the deficiency or dysfunction of the clotting factors in the intrinsic and the common pathway, like factor 5, factor 8, factor 9, factor 10, 11, 12, prothrombin, or fibrinogen, or liver disease. Okay, liver disease lead to reduced synthesis of coagulation factors. Heparin, even vitamin K deficiency also can lead to prolonged APTT. But for vitamin K deficiency, as 3 of the factors are in the extrinsic pathway, it is better to do a PT. And disseminated intravascular coagulation. So now we know that in disseminated intravascular coagulation and heparin, both PT and APTT are increased. Okay, so here is an interpretation of the screening test of the hemostasis in bleeding disorder. Like for example, if the bleeding time is increased but platelet count, PT, APTT is normal, then obviously it is a problem with the primary hemostasis. But the platelet count is normal, so it is a problem with the platelet function or the vascular disorder. Okay, then we can do a platelet function study. Then we can do a platelet function study which will be abnormal, or if not, we can do a assay for the von Willebrand factor. So this can be due to von Willebrand factor or aspirin, which will also lead to abnormal function of the platelet, or there will be disorder of the platelet function, uremia or storage pool defect. Similarly, if there is a increase in bleeding time but decrease in the platelet count, then definitely it is due to thrombocytopenia. Similarly, there are other interpretation which you can go through in this. I will keep it in, upload it. Okay, you can go through this and try to brainstorm. Okay, any problem with bleeding time, clotting time, prothrombin time, and activated partial thromboplastin time? Any problem, class?
No, sir.
Okay. If no problem, then I think we should stop here. This I just have a I just have one slide. The next is thrombin time. The thrombin reagent is added to the platelet pore plasma, and the time required for the clot formation is noted. The normal range is 8 to 12 seconds. This prolonged thrombin time is seen in disorders of the fibrinogen, like afibrinogenemia, hypofibrinogenemia, or dysfibrinogenemia, and chronic liver disease, and in fibrinogen or fibrin degradation products, and heparin, if the patient is on heparin. Okay, I will stop here. This is for today. We'll continue on Sunday with the third lecture of the bleeding disorder. Any problem? Any problem, anyone? Okay, so, if no problem, then we'll hang up and we'll try to you try to revise it, and then try to brainstorm. This is not a very hard topic, but you might find it difficult to correlate. So try to go through this, and if any problem, then we can discuss together. Okay, thank you.
Thank you, sir.